We wanted to make sure that all the providers who are working with our members know of all the Medicaid flexibilities that we have received from CMS, and also be able to answer your individual questions and make sure that we have the ability to make sure that you can continue to provide services as seamlessly as possible. So I'm going to turn it over to Traylor, and he's going to guide us through the process.
Hi, good afternoon. Traylor Raines, Deputy State Medicaid Director for the Oklahoma Healthcare Authority. Thank you all again for joining us today. I did want to give you a brief overview of where we currently stand at the Sooner Care Program. We did apply through the federal government for what's called an 1135 emergency waiver, which we applied for a few days after the initial emergency declaration was declared by the president. Through that waiver, we are given flexibilities within our Medicaid program that allows us to provide care in ways that we wouldn't necessarily have been able to outside of a national emergency. So I trust that most of you on the call are familiar with our global updates. And so if you go to our website, okhca.org, under the provider tab, there's a link for updates. If you go to that, there's a link for globals. That will give you all the information you need regarding recent updates to any of our coding and our expansion of telehealth services. So speaking of that, we have opened up our telehealth services broader than they are currently outside of the emergency period. We have added the GT modifier to most of our Sooner Care reimbursable codes. The GT modifier is how we identify if a code has been provided in an in-person or outside of an in-person setting and by two-way audio-video technology. So if you would just attach a GT code to a regular physician billing code, it should reimburse as it would a regular in-person session. Now, having said that, if you encounter any denials, please reach out to our provider services folks via email or phone, and we can do our best to resolve those denials on a case-by-case basis. We have also opened up telephonic evaluation and management codes for physicians that have not traditionally been open to be provided by telephone. And I will ask Karen Beam, can you remind me of what those actual codes are for this group if they want to provide a service by telephone?
I don't have them in front of me. Let me look them up and I'll get right back to you.
Okay, thanks, Karen. Let's see, so some other overarching flexibilities we've gotten are regarding member eligibility. So you may have read one of the first pieces of federal legislation in response to the COVID-19 national emergency was the Families First Coronavirus Response Act. As part of that act, we are, the state is eligible to receive an enhanced FMAP of 6.2%. Added on to our usual reimbursement amounts that we get from the federal government. But as part of receiving the 6.2 increased FMAP, there are certain provisions that we have to follow in order to pull it down. One of those is we cannot terminate member eligibility during the emergency period. The only time that we are allowed to terminate eligibility would be as if the member asks us to remove them from the program or if they're no longer a resident of the state. So if a member has come up for renewal during the emergency time, we're pushing that renewal out such that if they don't submit the right paperwork or they no longer meet income guidelines, or even if they age out of the program, we will keep them enrolled in Sooner Care until the emergency period is over and then revalidate at that time. So it also says you have encountered situations where you feel like one of your clients who is on Sooner Care has been unintentionally lost coverage during this emergency period. Please also reach out to our provider services department and we can work on that on a case-by-case basis. But no one should be losing eligibility during this time. We've also reached out to our partners at the Department of Human Services, who also process the eligibility for the age, blind, disabled, long-term care population, and they're aware of this as well. I'll flip back to, actually, I think we got a chat. Yeah, so on the telephonic codes, that's 99441, 99442, and 99443. So these are the codes that you would bill for an evaluation and management service provided over telephone as compared to a two-way audio-visual connection, in which case you would just attach a GT modifier. Now I'll refer back to Karen on guidelines around these, but it's my understanding that these are only available for established patients. Karen, do you want to clarify the billing requirements around these telephones?
Sure. It is for established patients only. That's per the definition. Again, the codes are 99441, 442, and 443 for physicians and nurse practitioners and PAs. And then other codes are 98966, 98967, 98968. And those are for other kinds of providers. And again, those are established by minutes that the provider is talking to the patient via the telephone.
Thank you for that.
Okay.
And I will note, I'm getting a couple of questions in the chat box, and I didn't do my usual spiel about housekeeping items. So I will remind everyone that we are collecting questions through the Q&A function. So you'll notice at the bottom of your Zoom screen, there's a chat box, and then there's one that says Q&A. So please direct all your questions to the Q&A box, and we'll do our best to keep up with those here. Some of them I'll be able to get to and type a live answer. Others I'll say out loud, and we'll try to answer as a group. But please know that this entire session is being recorded, and we will post it to our COVID-19 response webpage, along with written question answers that have been answered by healthcare authority staff that we're hoping to get posted within 24 hours of the previous day's session. So that website is www.okhca.org/COVID-19. If you scroll towards the bottom of that page, there are listings of all the webinars that we're providing this week and early next week. Also click on the link to see webinars from previous provider groups as well. There is the ability to sign up for web alerts on that page at the top. If you aren't familiar with our web alert system, you put your identifying information in email, and anytime we make updates to that specific page, you'll get an alert in your email inbox saying to go check out the page, new items have been added. So Dee or Karen may know the answer to this one. Has OHCA allowed for telehealth visits for well child care?
This is Karen. For now, the decision was made not to cover those via telehealth. We are in communication with other state Medicaid programs who are trying to work around that. So it could be changing, but for right now, we're not allowing that.
So we did receive a question in the chat box. Again, please ask your questions in the Q&A box, but there's a question around what is the GT modifier? So when you submit a claim, if you're not accustomed to having to submit it with a modifier, there are positions on your claim submission form following the CPT code area that you can add a modifier, which is usually a 2 alpha code. In this case, GT is what we use to identify if a service has been provided by telehealth. So anytime you provide it by technology during the emergency period and beyond, add the GT modifier to your claim. That way our system knows that you provided that via telehealth. So we have been told that we can bill new patient virtual visits. Is that correct? And again, I'll refer to my other folks on the phone, Mel or Karen or Dee, around virtual visits. I know that we did start covering that in rules a couple of years ago, and we have specific codes that are specific to virtual visits rather than a telehealth E&M code.
And Karen, I think we're using the E&M codes for all video face-to-face with a GT modifier, regardless of whether it's new or established. Is that correct?
Correct.
So the answer to that question would be yes. Just your appropriate E&M code with the GT modifier based on the level of service that was provided to that member.
Okay, and the question was in reference to, was their understanding they could use a virtual visit for an initial encounter for a new patient? But I know we clarified that the telephonic are for existing only. But for maybe here is an E&M code that would be done face-to-face, non-telephonic, you could do that on a new client. Is that correct?
That's correct.
Okay. So here's a question from a specialist. Is there still a referral from PCP required? I believe the answer to that is yes. So we're still, for specialty providers, we are requiring referrals from the PCP. I would also say if you run into issues where a client is not able to access their PCP for any reason, given the current circumstances, please reach out to provider services and we can work with those on a case-by-case basis. So here's a question relevant to a conversation that Mel and Karen and I had this morning. Should total time be documented or time in and time out? And I'm guessing this is in reference to evaluation and management codes. Karen, do you want to give our update on that or guidance?
For now, we're using the medical decision making for the level of the code. If it is something that would normally be allowed with the time, you would need to have your time in and time out, and then as well document outside time if it's pertinent to that visit and is necessary.
Okay. And for the telephones, Karen, will we accept total time, or does the provider have to document exact time in and time out?
That should be time in and time out.
Okay.
Because that's face-to-face time.
And we have a question from a podiatrist. Which telephone code set would they use? A podiatrist non-PCP? The 99441 or 98966 set?
They should use the physician codes, the 441, 3443.
Okay. Do you want any modifiers applied to the telephonic services, the 99441 set? And do you want them reported with place of service 11 or 02? My understanding is that we're not attaching a modifier to the telephonic codes because we know that those are provided by telephone based on the CPT description. We've not typically edited based on place of service 02. So unless Karen or someone else on the phone disagrees, you can use either place of service and the claim will pay.
Yes, it will pay.
Okay. So just to clarify, the telephonic codes 99441 through 443 are only for established patients in contrast to Medicare waiving this requirement. That has been our understanding up till now. I will say though that as you all know, we're all getting guidance on an hour-to-hour basis and things are changing regularly. So we do have our medical staff as well as our policy staff that are trying to stay on top as we can. So if we get further information through these webinars, we're definitely taking that back in-house and researching it, and we'll provide further guidance either through the COVID-19 response page or through a global update. As of right now, we're using for established because that's how the CP code was set up. But if CMS and Medicare are giving further guidance around that, we'll do our best to stay on top of it. Let's see, will we allow remote patient time frame, i.e. blood pressure monitors? Any of my, any staff on the line that be able to help with that one?
This is Karen. Those codes are not currently open, and we've not had any discussions about opening them.
Right.
For right now, they're not.
Okay. So we'll take that under advisement and continue to look into those options. Let's see. So what dates cover the emergency period? Good question. So the 1135 flexibilities date back to March the 1st. The actual emergency declaration itself was March the 13th. We opened up telehealth codes and telephonic codes March the 16th. Sorry for the varying dates, but the telehealth stuff started in the system effective March the 16th. What about using place of service 02 instead of modifier GT? No, on any telehealth codes, we need the GT modifier on it. That's how our system edits the reimbursement and processes the claim. The place of service is informational on our side, so it helps for us to identify where of course, where the service is provided, but we edit based on GT. So you can use 02 in addition to GT, but not in lieu of. So which physician types are covered in telehealth? MD, DO, OD, DC, etc. So that would be all of them. Anyone, if you're able in evaluation and management code now, continue to do that. The only difference is you would add a GT modifier to it. The Sooner Care covering COVID-19 testing, we are, and that testing and any related treatment cost to the members. And so we have waived all cost sharing requirements for COVID-19 testing, as well as any service that has the primary diagnosis of COVID related. Several commercial insurance, including Medicare, require a modifier 95 for telehealth. Medicare requires a GT. How would that be handled on secondary claims? So our TPL folks have informed me that if you note that on your EOB when processing the secondary payment, that we will take that under advisement and process it. So CMS is stating that we can use medical decision-making only for the level of care for two-way virtual visits. Will you accept this as well? We did have this conversation this morning, and so to clarify, there's Medicare requirements and there's Medicaid requirements. Medicaid can follow the path that Medicare goes on, but we can also be more flexible than Medicare in a lot of ways. So as Medicare is pushing out this guidance and allowing more flexibility, we are paying attention to that, and we're adjusting internally based on those flexibilities given. As of right now, it's still for medical decision-making time and not just time spent, but we're evaluating that moving forward. Telemed visits, do we use place of service 11? You can use that or O2. Both of those are informational. O2 is for telehealth place of service, but we do need that GT modifier. Are there stipulations for the telephone visits, i.e. do we have to attempt video contact first? Can we bill for telephone follow on a problem that we have seen for in the last 7 days? Good question. Karen, do you have guidelines around that?
On that, we would follow the code description, and it's all the services within the last 7 days are billed together.
Okay. So we have a question in the chat box. We have a telehealth visit and testing needed to occur. We have families drive to back door and ring doorbell for swabbing. Do we bill these all together or two different places of service? So I would, unless someone corrects me, my interpretation of this would be that you bill for the test as a separate billable encounter, and you can also bill for the telehealth visit that led up to that. Karen or Dee, is that correct?
Are they swabbing and then doing the test? If so, they should bill it all on one claim. Otherwise the claim will deny if they split their claims.
So it sounds like they're doing a telehealth evaluation management, and based on that telehealth visit, they come to the office and they do the swab and test. And so I think they're asking, is the E&M visit, can they bill those separately?
I think they're going to need to bill them together if they're billing all for the same provider ID. Otherwise, the claim would deny because it'll see it as a split service.
Okay.
And it'll deny the second claim.
Okay.
Yes, can you hear me? This is
Yes.
Dee.
Yeah.
Okay, yeah. What Karen is saying, that's correct, but I think I was trying to clarify the question. Was it just, can they bill both? They were saying E&M visit and the swab. Is that the question?
So the exact question, and again, please refer all your questions to the Q&A box so everyone can see, but it's in the chat box. We have a telehealth and testing needed to occur. We have families drive to back door and ring doorbell for swabbing. Do we bill this all together or two different places of service?
So they have a visit code and a testing code that they're asking about, but all the services are happening at the back door.
It sounds like the telehealth service probably happened in the client's home, then they drove to the office, tested there, is my guess.
Oh, okay, I got you. Okay, yeah, so what Karen was saying, that is correct, that they would have to at least be all built together. But then on each detail, you do have an option to do place of service on each detail on a 1500 claim form. Okay. So maybe that's kind of what they're asking.
Okay, so maybe they could do an O2 for the in-home telehealth visit and then 11 for Is the 11 the office place of service?
Yes, that's for the office place of service. That's correct.
This is Karen. That all sounds correct too.
Great, thank you guys. Let's see, are RHCs allowed to do telehealth visits? And if so, is the reimbursement the all-inclusive rate? So as you know, a face-to-face visit is required for an RHC to get the all-inclusive encounter rate. And so if the telehealth visit is done by video, two-way interactive audio video, yes, you could bill that with a GT modifier and you would get the encounter rate. Now, federal regulations don't allow for telephonic to be billed at the all-inclusive rate. We have requested flexibility through our 1135 for our tribal facilities, our RHCs and FQHCs to be able to be reimbursed fee for service for those telephonic codes. We've not yet received that flexibility from CMS, but we are following up with them to see the status of that. But to directly answer your question, yes, two-way audio video telehealth services by an RHC can bill the encounter. Do telephonic codes require the GT modifier? No, for physicians and other professionals using the telephonic CPT codes, you do not have to attach a GT modifier. Regarding rehab and LTAC facilities, do we bill as inpatient or as something different? Are modifiers needed? Good question. I don't know the answer to. Does anyone on the team?
I would assume that inpatient facilities still need to bill the same.
Okay.
I'm not sure how that would change.
Yeah, typically typically in all of these, the only thing that changes is the addition of a modifier. So Karen, would they add a DT to their usual billing or just bill as is?
If they're,
Inpatient claims.
yeah. Go ahead.
I was just going to add that inpatient claims, they don't use procedure codes, they use revenue codes. So there's really nothing to attach the GT modifier to on inpatient claims.
I agree.
Did you have something? Okay.
Okay, so it sounds like you would continue to bill as is.
If it's someone doing therapy telehealth to the member in the rehab or LTAC, they would need to bill that to the hospital. They wouldn't bill us any different, because that's all covered under the DRG for their per diem payment.
Okay. We have a question around if it is a new patient telephone only that has COVID symptoms and we need to test. Are these visits still coded by 99441 through 443? If they come in for it, we then bill as a 9920 code.
If they came in for testing and you did an evaluation and management service in addition to just testing, of course you could bill that. Again, you don't use the new patient, is not a we don't pay for new patient telephonic.
Okay, there's a question around, please clarify the 98966 to 68 codes.
This is Karen. Those are billed by physicians, by providers other than physicians, PAs, or nurse practitioners.
Okay. Next question, are these services only covered for COVID-related diagnoses? No, so the evaluation management codes with a GT modifier, as well as the telephonic codes, are for any medical services that you would normally bill for using E&M codes. Unrelated to COVID diagnosis. The part about COVID-related diagnoses is that any testing and treatment services with that diagnosis, there will be no cost sharing to the client, and they are covered by Center Care. Y'all are asking some hard ones today. So what code are you accepting for collection of specimen only?
This is Karen. I saw the code the other day and meant to look it up, and I didn't get a chance to. I'm not sure if we have that code open or not. That's one we'll have to get back on.
Okay, thanks. Is Medicaid allowing the new CMS rule for code level selection during the public health emergency? CMS is allowing the use of total time spent on the visit or medical decision-making for code selection. So I mentioned this earlier, and this may have come in while I was responding or before. Currently, we are using in Sooner Care medical decision-making, we are looking at the guidance being given to us by CMS and the Medicare program, so that may change. So keep your eye out on global updates as well as the COVID-19 response page for any updates to that guidance. Here is an opportunity for a plug. We are a speech, occupational, and physical therapy doing telehealth services. If this is a speech therapy, we are using the GN modifier for speech, GT for telehealth, and the telehealth location. Is this correct? First, I would note that we did do a webinar specifically for PTSD OT on Monday. So the list of written questions and answers, as well as the video webinar, is on our COVID-19 response page, which may have a lot of helpful information for you there. But in addition to that, Karen, do you have guidance? I haven't seen a GN modifier before.
That's the modifier they use for speech therapy.
Okay.
There's one for PT and OT as well.
Okay, so they would use the GN modifier in the first position and then GT modifier in the second position. Is that correct?
Yes, correct.
Okay. And then you can use the telehealth location or as place of service O2, but we edit based off of the modifiers. Let's see, there's questions about crossovers when other payers use 95 modifier. Our TPL department has been informed of this and they know it. And they have they're accustomed to doing crossover claims on telehealth previously for previously covered service. But they mentioned this morning to note that on your EOB.
Yes, and trailer also, usually we accept claims, usually the way they file them to Medicare, we generally accept them the same.
Okay, great, thank you. Are there any temporary modifications to the provider enrollment process to contract providers being emergently credentialed to assist during the pandemic? OHC enrollment is efficient normally, but asking in case expedited processes have been implemented, such as those put in place for Medicare. Yes, so I didn't mention this at the top of the meeting, but we did receive flexibilities to waive certain provider enrollment requirements that we would normally have in place, such as site visits, the fingerprint-based criminal background checks, as well as a few others. And so provider enrollment is processing those as quickly as possible. What I would say is we're only waiving those requirements during the emergency period, so that if you decide to continue to be a Sooner Care provider after that period is over, we will go back and require all of those elements. But in order to more easily enroll providers during the EP, we are waiving those. And from what I've heard, provider enrollment has not had any issues in processing those quickly during the time. Okay, so we have a G2023 is the new Medicare code for collection of SARS-CoV-19 specimen. Sooner Care does not recognize this code. Is there a code to use for code you said you saw the other day? Are we evaluating that for coverage? Do you know?
We sure will.
Okay.
I don't know that, at least in medical, we haven't looked at it yet, but we for sure will, and we'll get an answer back as soon as possible.
Thank you. Should we be confirming consent to treat with patients with telehealth as a matter of practice? Should this be documented in the chart? So you would follow your normal consent to treat processes as if they were in person. The state of Oklahoma and thereby Sooner Care does not require a separate consent just to provide the service by telehealth. So you would collect and get whatever consents and authorizations you need from the client that you normally would, but you do not need anything in addition to that to provide the service by telehealth. So can they do a new patient via e-visit, or is it established only? So you can do a new patient visit using telehealth, which is two-way audio visual, and bill the corresponding CPT evaluation and management code along with a GT, but you cannot bill a new patient visit using the telephonic code. Oh, I see a note that provider enrollment has in fact been awesome. So it's good to hear that. Let's say, you say any copay would be waived if billed for positive COVID. However, I have submitted a claim for a positive COVID patient before April 1st, and the ICD-10 code UO 7.1 was not effective yet. I use B34.9 to claim process with a copay to the patient. Is there another code being accepted? Great question. So we were able to backdate those ICD-10 codes as well as the new testing codes back to a point in February. However, CMS would not allow us to load those codes and cost sharing waiver requirements into our system until April 1st. So if you go back and rebuild that claim, it as you originally did prior to April 1, it should pay correctly now without deducting that copay. If you do have any problems at that point, please reach out to provider services. I believe, from what I understand, and Dee can probably confirm, our system is working now, so where it does not take the copay out. Is that right?
Yes, that should be correct. So we can look at any claims they had billed if they give us an example.
How will we pay per member month payment? How will pay per member month payments be calculated with deferment of well child care over 2 years of age? Currently required to have a checkup in the last 18 months to receive payment.
Are they talking about the care coordination payment for choice?
Yes.
We would count the telephonic visits that are billed as part of the look back period, so that should not be a problem. If it's related to a new patient coming into your practice that you have not established care with, we'll need to go back and talk to our system folks and see what modifications or recommendations they have to make sure those care coordination payments do start.
So far, I believe we have not allowed well child care visits over telehealth or telephone, though. So maybe, how about this? To the questioning party, we'll evaluate that internally as well to see if maybe we should open those codes for well child. So our intent is to not, of course, penalize any provider during the emergency period for services you can't provide based on CDC social distancing guidelines. So we'll look at that and confirm and get that in writing to you as well. Let's see. What place of service would we bill for virtual visits, such as FaceTime or Skype? Would it be O2 or 11? Also, would these need the GT modifier? Yes. So the place of service is not as important to us as the GT modifier is. You could use either O2 or 11, but the claim will edit based on the GT. Since you mentioned FaceTime and Skype, I'm not sure if I've mentioned that in this meeting yet or not, but the federal agency charged with oversight and enforcement of HIPAA has given guidance that they will not enforce HIPAA guidelines around the use of audiovisual technology during the emergency period, such that a technology platform that would not have previously been HIPAA compliant could be used only during this emergency time. So for instance, FaceTime is currently not HIPAA compliant because Apple has not signed a BAA arrangement with that federal agency, but it would be okay to use during this time, as well as non-healthcare related Zoom and others. Let's see. We'll give it a few minutes to see if any more questions come in. Again, I'll remind everyone that the webpage where this will be posted is okhca.org/COVID-19. Lots of good resources out there, as well as at the bottom page, all the links to these webinars, as well as links to the video recordings, as well as written Q&As. So one more time, are you saying that we can use Skype and Zoom specifically? Yes, you can use any two-way audio video platform. And during the emergency, the federal agency in charge of enforcing HIPAA has said they will waive enforcement of that provision of HIPAA. specifically for those platforms. Now, there are exceptions to that, of course. You can't do a Facebook Live or video through anything that is known to be public facing. But yes, through those other two ways, you can use those. So are these services going to be allowed after this emergency ends? We of course are open to all possibilities. I think that necessity is the mother of all invention. So during this crisis, we are evaluating closely. We have our data folks that are monitoring on a daily basis the uses of telehealth. Now, I would say it would be good on your end if you want to create some kind of provider satisfaction survey or collect informal data on your side to show the efficacy of these services that you're providing in a new and novel way. And we'll probably be asking for that information at the end of the emergency period to see if we can, in fact, maybe look at expanding our telehealth and telephonic service array in the future. So, yep, questions and responses being posted on the website, absolutely, on our COVID-19 response website. So Governor Stitt stated that there are plenty of supplies available for providers. How do we obtain N95 masks, gloves, PPE when our regular suppliers are back ordered? Great question. I've also heard the same information. I'm not sure where one goes. I do know that the state has recently appointed a PPE czar for the state to manage the supply chain for these supplies. So we will work in finding out more information for you on that. All right, well, not seeing many other questions come in, I will kick it back to Melody or see if there's any other comments Karen or Dee have before we close down the meeting.
Okay, so I'm going to assume Karen and Dee have no other comments. But thank you so much for participating today. If it would help in the near future, we would be more than happy to do a second to make sure that we all move forward in taking care of the population during this crisis. We are also open to specific webinars through provider services. If you would like one related to submitting claims, if you'll just reach out to us, we'll make sure that Dee and her team are able to do that for you. And if you have any other questions, please feel free to reach out and let us know how we can further assist you while we work through this crisis together. So thank you again for participating.